Hello and welcome to the Oncology Journal Club podcast, where oncology papers meet real-world practice. I'm your producer, Rachel Babin, and joining me again are Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. Together, they dive into the research shaping cancer care, the important, the intriguing, and the sometimes controversial. This podcast is proudly produced by the Oncology Network. Head over to oncologynetwork.com.au for the show notes with links to all of the papers discussed today. Okay, over to you, Craig.
G'day. What fucking episode is it again? Starting again. G'day. It's Series 4, Episode 6. Welcome, everybody. It's great to be here with Dr. Kate Clarke and Professor CJ Jackson. Hello, peoples across the ditch.
Hello, Craig. What episode was that again?
Series 4, Episode 6, I think.
6. Good.
How are you, Chris? Oh, pretty good, thanks, Craig.
So, is everyone back to normal after ASCO? We had two fantastic, I think they were fantastic. I learned a lot by listening back the ASCO updates. So, if you missed reading or going to post-ASCO meetings, or just want to refresh it again, download those episodes. And today we're back to normal. Is there such a thing as normal on this podcast? I'm not really sure. Bit of a wide-ranging Cook's tour of recent papers in oncology. Let's hope people enjoy it. Who's going to go first?
I've got a negative paper to talk about today. This is one for the argument files at your NDT, should you ever be dragged into this conversation. Systemic therapy, gastrectomy, cytoreductive surgery, and HIPEC versus systemic therapy alone for gastric cancer with limited peritoneal metastases, the PERISCOPE II clinical trial. PERISCOPE II asked whether adding gastrectomy, cytoreductive surgery, and HIPEC to systemic therapy improves outcomes for people with gastric cancer and limited peritoneal metastases. This was an academically sponsored European phase 3 trial funded by public and charitable organisations, not industry, which is important. It tested a complex, expensive and widely used intervention that's never properly be compared to systemic therapy alone. Patients who were enrolled had a PCI index of below 7. So those who do GI malignancy, PCI is less than 2 centimetres in size, and which of the 9 areas of the abdomen is it in? They get a point of 0, 1 or 2 for each of those things. Colorectal cancer would usually say PCI of 11 or less would be considered for HIPEC, and this was less than 7, so that's quite a conservative, limited burden of peritoneal disease and gastric cancer. Or they could be WASH positive, so if you did a laparoscopy and they had a washing sort of positive, they're eligible as well. And it was a clean comparison of HIPEC versus surgery.
Quick question, Chris, just clarify that. So the 7, is that the total size of that's a number?
So PCI is a score. You get 0, 1 and 2 points for every one of the 9 areas of the abdomen. 0 is nothing, 1 is a deposit less than 2 centimetres, and 2 is a deposit greater than 2 centimetres. And so you add up 9 of those, so the most possible score would be 18, and less than 11 is, not much, and less than 7 is quite low. So it's a truly limited peritoneal disease and gastric cancer.
These were low volumes, in other words.
Yeah, so low volume peritoneal disease, absolutely. And in Western patients, not in Asian patients, because Asian patients have a different disease biology, usually a different primary location in the stomach, often different risk factors, and have often had different primary surgery as well. So patterns of relapse are different. So these are more representative of the types of patients we would see in our MDM. Already I'm going to say how much I love this study because it had a primary endpoint of overall survival, the best possible endpoint in all advanced cancer trials, which is exactly the right choice. A major intervention intended to prolong life. So if response rate or PFS wouldn't have been enough. And the result was clearly negative. Median overall survival was 16.6 months with systemic therapy and 15.7 months with surgery and HIPEC, hazard ratio 1.1. No suggestion of benefit. The curves were completely overlapping. And PFS was also not improved in the intention to treat. And the harms were substantial. Grade 3 or worse adverse events were worse in the HIPEC group with 42% compared to 20% in the control group. Serious adverse events occurred in 44% with HIPEC compared to 6%. And under those who went surgery, anastomotic leak occurred in 27%, ILS in 35%, and 3 patients died from treatment-related complications. So just don't do it. There are some issues with it. I mean, 16 months with systemic therapy is quite good. Standard median overall survival in gastric cancer studies these days is about 11 months. If you add in second-line therapy, you might get up to 13 months or 16. Some people might say that was quite good. But this study enrolled people after they had not progressed on 3 cycles of chemotherapy. So they were already the good responders. So I think that probably accounts for the better performance of the control arm. And we don't actually have enough information from the appendices or the trial report itself on what the amount of first and second line therapy was and what the types of therapies were and how many people got PD-1 therapies and how many got subsequent studies, that type of thing. So a little bit of insufficient information. The bottom line is straightforward. It selected patients with gastric cancer, unlimited peritoneal metastases, adding gastrectomy, cytoreductive surgery and HIPEC does not improve survival, markedly increases morbidity and causes treatment-related deaths. This is a highly valuable academic negative trial with the right primary endpoint, answering an important clinical question in an appropriate population which is comparable to ours and should reduce the use of a hazardous intervention outside of clinical trials in our population.
Great. So I guess the other reason people on the control arm did better than expected is because the pattern of relapse was peritoneal rather than liver or elsewhere. Chris, the other question I had was, in the constellation of other literature, where does this fit? Like, have there been positive studies for peritonectomy and this refutes that, or is the first sort of robust phase 3?
Well, there was the German HIPEC study with no overall survival benefit observed for people with gastric cancer and peritoneal metastases treated with cytoreductive surgery and HIPEC compared to those treated with cytoreductive surgery alone. So that was a HIPEC study. And then you've got the Renaissance trial, which was another German randomized controlled trial showing no survival benefit for people with gastric cancer and oligometastatic disease who underwent extensive surgical intervention compared to those who continued systemic therapy. So what that shows is in the suite of studies of do you resect oligometastatic disease in gastric cancer? No. Do you resect limited peritoneal disease in gastric cancer? No. Does HIPEC add much to peritoneal surgery alone? No. So what's the right treatment? Metastatic gastric cancer? Drug treatment.
Can I just ask a question? In the trial, they included the washings positives only. Did they show any signal of anything?
No subgroup analysis that I could see on that particularly, Kate. So no forest plots reported there in that study. Good question, though, because the WASP positives...
Dredging, I think, Kate.
Yep. The WASP positive producing group, aren't they?
We shake our heads a lot when if it's only a few cells floating and washing, and you feel like you're writing people off on the basis of a few cells floating in washings. So I would love some data in that space. So if the investigators are listening, if they could share with us the wash positive only data, we would be fascinated. Of course, it's curiously reading the paper to see if we can find it.
We'll try and link up in social media then about that on LinkedIn or X, Blue Sky. All right, Kate, what was your paper today?
So my longish paper is the Neo Summit 01 trial. This isn't earth-shattering. This is, I think, confirmatory. And unlike Chris's paper, this is in 100% Chinese population, mostly Guangzhou, which is a lovely the south region. It was looking again at gastric and gastro-oesophageal cancer. This is chemo plus or minus an anti-PD-1 perioperatively. The chemo, this being a Chinese population, is Capox or SOX, being S1 and oxaliplatin.
Mm-hmm.
And the anti-PD-1 is teripalimab, which interestingly is $200 a dose in China and $8,000 a dose in the US. So, wow, which is cheap by anti-PD-1 status, but great. So only 108 patients, but they got 3 cycles preoperatively, 5 cycles planned postoperatively, and then a further 6 months of teripalimab in that arm. The 3-year event-free survival, 75 versus 50-something%. The overall survival at 3 years, 81 versus 72%, which is bang in line with what you'd expect from Matterhorn, but 1 year further over fewer patients. So I think it's confirmatory that an anti-PD-1 does assist curative intent therapy for people with gastric and gastro-esophageal cancers. A shout out to this investigator was, although they included DMMR patients, 3 in each arm, they then excluded them from their analysis once they figured out that they should do well. So this is a purely pMMR group that we're talking about in the analysis. So yeah, nice paper. The other curious thing, and maybe gives us some hope after our very negative discussion from Professor Jackson, is that the addition of anti-PD-1 in this small trial decrease the peritoneal relapse rate from 40% to 15%, which is interesting. It's like most of the distant metastases that they avoided was peritoneal. There's only 108 patients, whether that's just a fluke or whether there's a signal in that. So I was curious about that.
That was interesting, isn't it? Yeah. Well, I'd like to name it after my Conservative Party friends, Tory Palliative.
That makes it easy to say, doesn't it? Yeah. Yeah.
Well done, Chris. That's very useful.
Yeah.
Today's podcast hint.
The brand name is even harder to say. It is LOQTORZI, Loctorzi, I suppose. But yeah, there you go.
Yeah, with the molecule, is it IgG1, IgG2, IgG4? Anything particularly special about it that is different from the other PD-1 inhibitors?
No, not that I can see immediately. So I don't think, it's flashly humanized or run through a mouse first or whatever, as they're all trying to claim. I think it's just a standard anti-PD-1. It has had FDA approval for a very long time because it was first tested in nasopharyngeal cancer, which is obviously something the Chinese are much better at than the rest of us.
Kate, was there a tail on the curve?
In terms of long-term survivors?
Yeah, because it's going to segue into the paper I'm going to do in a sec.
Not as yet, because we're only so although they're reporting 3-year, median duration of follow-up is only 40 months, so only a few months longer than their reported EFS.
So I picked a bit of a curveball paper, I guess, not one of a practice-changing new treatment. This paper is called Rethinking Treatment Intent Beyond the Curative Palliative Binary in Modern Oncology. It's in JAMA Oncology, sorry, just out. It's a viewpoint. I was doing some research about this topic about endpoints recently. Some people use other endpoints, like there might be just to delay symptoms or other headings, other categories of treatment intent, but a lot of people use this binary, curative or palliative. So this paper sort of points out that in the modern oncology area, maybe this doesn't fit very well as a binary construct because of the longer survival we're seeing tails of curves and long-term survivors, perhaps cures in people who had metastatic cancer that previously thought to be incurable, and melanoma and lung cancer springs to mind. But even they actually quoted the example of in metastatic gastric and esophageal adenocarcinoma studies with immunotherapy, we're seeing in some studies tails on the curve with some very long-term survivors. So this is something that's sort of risen in the era of targeted therapy and immunotherapy. So they postulated that maybe with these advances in treatment, that blurring the lines, we should move to some other type of construct because it's no longer fit for purpose. And they're saying the problem is when you present it as this sort of binary choice, even though, for example, you might be intending, let's say someone with resectable, again, they use the gastric cancer example, someone with resectable gastric cancer receiving perioperative chemoimmunotherapy might be told the treatment's curative, but despite that, 25% of people die within 2 years of embarking on the treatment. And so similarly, despite improvements in resectable pancreas cancer with FOLFIRINOX added to surgery, a third of people still die within 2 years and many more will die in the 2 years after that. So people may then delay making choices or about treatment because of that overly optimistic spin on things. And equally, even though you're starting a treatment with someone with metastatic disease and they may well die of the disease, there's some people, it's palliative intent, but some will be long-term survivors. So how do we get around that? And so they were saying that maybe we should invent some new terms, new categories. And I'm not sure that they've quite got these right, but this is what they suggested. One was a treatment aimed to increase the chance of completely removing the cancer and thus cure you from the cancer. So that would be in the neoadjuvant space. It's a bit of a mouthful, isn't it? A treatment aimed to prolong life and prevent symptoms by preventing tumour growth for as long as possible, but with less than 5% chance of completely removing the cancer. Or a treatment that does not try to slow down the cancer, yet does attempt to reduce the symptoms. So they've come up with these different categories. So what I think one of their useful suggestions was structuring the discussion around outcome ranges or possible scenarios rather than a binary picture. And they thought there needed to be further work in this space. We need to maybe use more written materials, including within informed consent forms to lay out these scenarios or ranges rather than having this rigid dichotomy. So they were saying the conclusion was they were calling for a transition to a flexible and precise lexicon of treatment intent that uses precise goal-aligned language and communicates prognosis with outcome ranges or outcome scenarios. Yeah, I'd love to know, Kate or Chris, your thoughts on it.
There are 3 audiences, and there's probably more, but I think there's the patient in whānau, there is the MDT decision-making group, and then there are other clinicians who have involvement with this patient for other illnesses. And I think we don't communicate well with, we can probably communicate well within the MDT, and at least in some of the diseases that I treat, we now have radical. We don't use the word curative, actually, we use the word radicals. We have radical, as I'm trying to eliminate the cancer. We have disease control, and then we have palliation. And we understand within the MDT what those 3 things mean within the disease. But I think it's really hard when a patient has a heart attack and ends up in ICU who's on palliative hormone therapy for metastatic ER-positive breast cancer, because they're actually got a life expectancy of years ahead of them. So that is really interesting. And then in terms of the patient, I like the Australian research group that talk about best case scenario, worst case scenario, and usual scenario. I really like that structure. And it doesn't have 1,000 words in each title. So I try and do that. And then I tell the patient about things like conditional survival, disasters, unexpected events, and sometimes we're wrong. Because I've got one dude who progressed through first-line chemotherapy. We gave him a little bit of IO, and all of a sudden his esophageal cancer has disappeared. That happened, I think, 2 years into his journey. And we've all got stories like that. So I think we have to be open to uncertainty as well.
Pretty agree, Kate. I think the good case, bad case, typical case is a really good construction. And I think your example of the ER-positive metastatic breast cancer with bone-only disease with a life expectancy of more than a decade is an excellent one where palliation, well, yeah, strictly according to our definitions, it is. The one that I really struggle with in my practice every day is the melanoma brain metastases, where at Nivo, they've got a 50% chance of intracranial response if they're asymptomatic, but also a high chance of death in the next few months if it doesn't work. So it's either going to be a total train wreck and a complete disaster, or they're going to be cured. And those two quite dichotomous situations, those two realities that patients have to live with, are very difficult. And then you have the person undergoing a Whipple, and we know that most people undergo a Whipple are going to recur and die in a very short space of time as well, which actually melanoma brain metastases have got a better outcome than Whipples do in many ways, just the timeframes are a wee bit different. So I think reevaluating the prognosis and updating it frequently is a really important thing to do as well, understanding that prognosis is not a one-off conversation. It's one that you have to revisit, and I personally revisit that at every change in line of therapy. It's important to do that. And we started on each of our clinic letters, we have a diagnosis, molecular phenotype, treatment that they're on, and then a treatment intent. And so we use languages like, of the brain metastases, for example, likely palliation with a small chance of cure or high chance of long-term disease control. So phrases like that, which we use to try and communicate in lay language for those patients that get admitted to ICU or for those patients who are seen in primary care, where they can have some language to use as well, which isn't quite that classical palliative curative, which, as you say, is not all that helpful and doesn't reflect the full spectrum of possible outcomes.
Yeah. So shout out to Belinda Keeley and her colleagues in Sydney who led on some of this work. They published a paper in 2022. I will link that in to the show notes. But it was interesting that this international group was putting it out there that, you know, we also needed to think about changing. This came up in a couple of contexts recently. One was defining a minimum data set for MDT software in Victoria. And at the moment, it's that binary choice, and everyone's expected to fill in either curative intent or palliative, which doesn't quite fit it in the modern era, does it? But it's not so simple to create some more drop boxes for the MDT report, I think. Anyway, there you are.
We've discussed this a lot with our data collection exercises too, Craig, and then people start to get into quite reductive. Well, does it have to be a 5% chance of cure, a 2% chance of cure? What degree of life expectancy?
Yeah.
And then at some point you have to draw lines and appreciate the rules we use for these terms for data collection purposes are imperfect.
Before we get back to the papers, if there's a study you think we should be covering on the Oncology Journal Club podcast, feel free to send it our way. You can join the Oncology Network. Remember, registration is free, and leave us a voice note on the OJC page. That's at oncologynetwork.com.au. Or come and chat with us on our socials. And physicians, please don't forget that you can claim CME points for listening to the show. All right, back to the Journal Club.
Chris, I think you got a couple of other quickies to tell us about.
Yeah, I've got a couple of quickies. There's a paper in the JCO just out this month, which is called No Smoker Left Behind. Now, we know that even people with metastatic lung cancer who quit smoking live longer and have fewer complications than people who continue to smoke. So quitting smoking, even when you're diagnosed with advanced cancer, is a good thing to do. And people often say, oh, what's the point? I've already got cancer. What's the worst going to happen? I'm going to get more cancer. You go, well, actually, you're going to live longer if you quit. So it's never too late to quit. But also getting people to quit smoking remains a challenge. And it's something I think probably we don't do all that well in the clinic, actually, probably, because it's a bit confronting. And perhaps we feel it's a bit victim blamey to talk to people who've already got cancer about their smoking cessation habits. So it's not something which is done well, in my opinion. This particular intervention was undertaken at the University of Chicago Comprehensive Cancer Center, and patients were systematically contacted via interactive voice response phone calls, texts and emails for up to 6 months. So it was a whole-of-system approach where the organisation took on the responsibility for catching up with people rather than just leaving it up to the individual clinician. And with this systematic response and intervention effective, they help people quit smoking. About 10% more people quit smoking with the intervention than didn't. Only about a quarter to a third of people who were eligible indeed enrolled, and the cost per patient referred to treatment was about $400 and the cost per quit was about $6,000. So it does cost a bit in terms of the intervention. The engagement rates aren't huge. But it does actually help some people quit smoking. And if you're looking at things that improve overall survival, then this is one of them. So it's important, I think, for institutions and organisations to think about how they engage with these quit programs. And my third and final quick bite was another paper in the ctDNA suite. This is another paper in circulating tumour DNA. It's a Japanese study which looked at the prognostic and predictive value of circulating tumour DNA in people who'd undergone metastasectomy in metastatic colon cancer. Randomised trials of chemotherapy after liver metastasectomy have generally shown improved DFS without convincingly improving overall survival. JCOG 0603 was particularly sobering, where post-operative modified FOLFOX6 improved DFS but not OS, and numerically survival went the wrong way. Meanwhile, ctDNA guided treatment's not automatically better. The Australasian Dynamic Stage 2 study, ctDNA guidance reduced chemotherapy overall, but exposed a higher proportion of treated patients to oxaliplatin without evidence of overall survival benefit. So we've got prognosis a lot, we don't have predictive. Part of the theory in Stage 2 and Stage 3 is maybe we just don't have very good escalation strategies and more treatment intensification, whereas we do have that now with bladder cancer. But in liver metastasectomy or post-metastasectomy in colon cancer, is that a group where you could escalate therapy if they're ctDNA positive? Well, it's a possibility. This is a prospective registry analysis from Circulate Japan. It was observational, not randomised, 300 patients following curative intent resection of colorectal liver metastases using ctDNA personalised tumour-informed assay 2 to 10 weeks after surgery. And unsurprisingly, post-op ctDNA was an exceptionally strong prognostic marker, where those with ctDNA positivity had a 4-fold greater risk of recurrence and a 9-fold greater risk of death. So again, another study which shows ctDNA is strongly prognostic. Is that enough to mainstream it? No. The provocative finding was among ctDNA positive patients who'd undergone upfront surgery, adjuvant chemo was associated with a markedly better DFS and OS with an adjusted hazard ratio of 0.27. So the adjuvant chemotherapy seemed to work in people who had positive ctDNA. So that was that. That was not reproduced in patients who'd already received neoadjuvant chemotherapy, and this cohort post-op chemo was not associated with better outcomes, irrespective of circulating tumour DNA status. So a little bit more nuanced the situation there as well. ctDNA clearly prognostic, whether it's genuine and predictive, is much less certain, and I think we may need a randomised trial in this exact context where the role of adjuvant chemotherapy in post-op liver resection remains somewhat controversial now.
And are those trials underway, Chris? Do you know? Or
I don't know, probably, but I don't know actually what the current status of ctDNA trials in stage 4 colon cancer are. Correct? Do you have any inside running on that?
No, I don't know off the top of my head. Kate?
What in your group, what are the proportions of ctDNA positive patients?
This is a quick bite. This is a quick bite, Kate.
Oh, I'm just curious because if we're looking at 40% long-term survival, are they just the guys that are negative? It would put 100% of people with isolated liver mets through quite an intensive and we expect about 40% of them to do well long term. So are 40% ctDNA negative? Is it that straightforward, or is it? So that would be what I would be curious about.
I need to dig out the paper. I'll tell you what. Why don't we look that up and put that in the show notes later?
Yeah, perfect.
This is probably a silly question. Any access to circulating tumour DNA tests in New Zealand?
There's a whole bunch of people who are doing it investigationally in the research context. But again, they're personalised ones rather than the bigger panels, Craig.
Yep, great. Chris has got some kind of boutique beer and Kate's got, it looks like a Savvy Blanc. And it's too early in the day here. I've got nothing of a water.
I have got Tiny by Garage Project, which is tiny but mighty, which I could say is like my ego, tiny but mighty, is non-alcoholic, less than 0.5% beer, made by Brew Project New Zealand. Very tasty. It's the tastiest non-alcoholic beer I've ever had. But now, just to show that I'm a modern man, I'm moving on to my kombucha.
Oh, my God.
So Tiny is made in Wellington. I'm not drinking Sauvignon Blanc once. I'm drinking sake, which is made in Queenstown, which is just down the road from Chris. Well, 4-hour drive in the dark. But yeah, just the road from Chris.
Just across the hill.
Yeah. But I want to talk about smoking too, talk about vices. I went to ESCO Breakthrough for a variety of reasons, but one of them to hang out with Martin Stopper, which is always fun. Kia ora, Martin, if you're listening. And Chinese University, Hong Kong, they did a very similar study to the one Chris presented, but probably significantly cheaper. So people got one research nurse visit of 5 to 8 minutes. Then they got 6 months of instant messaging on a text message and 4 educational videos that they could look up themselves versus people just being told to stop smoking. And the self-reported quit rates at 6 months went from 17% to 26%. So delta very similar to Chris's intervention. And the thing that I find hilarious is they also tested for saliva cotinine, which apparently is a nicotine byproduct, and expired air carbon monoxide levels. And then your real quit levels go down to about 2%. But to be fair, smoking is ubiquitous in Hong Kong, so I suspect there's a whole lot of passive smoking going on there. So that was interesting. So if you give people a little bit more support, you can get some more people over the line. My other quick bite came out of also ESCO Breakthrough. There's a supportive care session where the presenters were all people who would not coming from backgrounds of a lot of experience being principal investigators. Many of them, this was the first trial that they had designed or run themselves. Many of the people were very young looking. This one comes out. I am getting old. I'm 50 in October. This was coming out of India. And I think this is really interesting. So this was looking at 150 adult cancer patients. They were the people who were about to start oral morphine. They were 1-to-1 randomized to oral dexamethasone, given a few hours before their first morphine dose. And the vomiting rate is halved. And that's a very simple intervention. They did point out it's a small group. The 6-hour lead time means that you have to leave people without morphine for 6 hours after you think they might need it. So maybe the lead time needs to be figured with. And they didn't have a placebo. But I think there's something in that. And by day 5, most people have settled down whether they had the steroids or not, but it decreased nausea and vomiting on day 1 and day 3. There was an interesting conversation thereafter in the room about why are people still using morphine when things like fentanyl and stuff are better. And a lovely lady from India pointed out morphine's dead cheap and still very effective, which I thought was very brave of her in that environment. And shout out to ESCO Breakthrough, which is finding who it is and it's becoming an increasingly useful meeting.
Where would you recommend goes to ESCO Breakthrough these days? What sort of people would it
I actually think that young investigators should consider presenting at ESCO Breakthrough. It is a small meeting. It's a very friendly meeting because it is in Singapore now. And actually, to be fair, when it was in Japan too, it is a meeting where you eat at least every hour as part of the meeting. In the poster sessions and stuff, you will have the most amazing researchers walking past and discussing your research with you. It's access to worldwide research in a much more intimate environment. And yet you also have access to incredible speakers. One of the speakers from the Chinese University of Hong Kong has done absolutely remarkable work on the tiny little bits of DNA, the size of the bits that float past. And I've forgotten the word. Anyway, he is just incredible. and has just been gifted simultaneously honorary doctorates from universities all over the place as a result of his work. But that's just a really interesting meeting. So young people, I think, particularly from Asia Pacific, who want to meet like-minded researchers and find collaborators, it's a really good place to start. And Singapore, so it's easy to access.
Cool.
Yeah.
Thank you, Kate. Sounds a bit like San Antonio Breast Cancer Conference used to be. Yeah. I don't think it maybe still is, with cocktails and snacks at the end of the sessions, at the end of the day. All right. I've got a few things to mention. First one is entitled Cancer Workforce, a Global Crisis, a Lancet Oncology Commission. So there was a bit of mainstream media about this, but this group did some projections modelling on the global landscape for 17 common cancers and 18 workforce personnel types, and looked at how many cancer workforce people we might be short. And of course, this problem is going to be, the biggest projections of shortages are going to be in Africa and Asia, with a rapidly aging population in those continents. But the projection is something like a shortage of 100 million people in 2050. The largest shortages being 65 million nurses, 16 million radiologists and pathologists, and of course that's exacerbated in Africa and Asia. But if we're able to scale up the workforce to avoid those shortages, it's projected to avert 170 million cancer deaths and yield net economic benefits of US $120 trillion between 2030 and 2050. So that was particularly interesting, and they called for sort of global action with establishing workforce and cancer registries, cross-sector international partnerships to improve access to education and research training programs, implementation of task-shifting digital health and artificial intelligence solutions to improve workforce productivity. So it was interesting and quite sobering.
Craig, I'm going to get my little trumpet out. I got invited to do a guest editorial to accompany that Lancet Oncology Global Workforce. So that's it's in the same issue of the Lancet Oncology. Yeah. But look, a couple of things. I found the paper, or the whole commission, absolutely fascinating. It's written by some really big names internationally. It's very well written, a very comprehensive work, and the most comprehensive look at the workforce issue. One of my part-time jobs is helping the National Cancer Services do their planning stuff. And one of the things which was quite salient out of that was that the workforce crisis was only about 10% doctors. The rest of it was associated with nurses, with pathologists, with path techs. Not the pathologists aren't doctors, but the non-patient-facing workforce as well. So like the numbers of people who we were looking at was mostly non-medical and radiation oncologists. So quite a lot of other specialties there. And we often think in oncology workforce crisis as only med-onc, rad-onc, surg-onc, but it's much, much bigger than that, of course.
Yeah.
And the other thing I think that we need to wrestle with is that the oncology workforce is actually a global development issue, because as the West gets, more and more desperate for workforce, because of course the workforce crisis hits the West as well, is that we start to import people from other countries. And New Zealand and Australia are pretty bad at pinching docs and nurses from the Pacific, and from low and middle income countries like Philippines, for example, Indonesia, next door neighbours, pinching their workforce for healthcare workforce, healthcare assistance, etc. As well. So that becomes quite a big development issue when those countries train up their workers and they then shift to our country as well. So we have to be careful about that, which is difficult because there's a balance between human rights, of the rights of people to migrate and to move, and yet at the same time it being a development issue, that how can they possibly sustain their own healthcare systems if we keep pinching their staff all the time. In New Zealand, the healthcare workforce is 40% overseas trained doctors, 40%, 4 out of 10 doctors are overseas trained.
Yeah.
So I think it's a country's obligation to actually pony up and develop their own workforces to meet their own needs and not pinch other countries' workers off them.
Great. Thanks, Chris. So I'm going to find that editorial and A, read it, and B, we'll include that also in the links on the show. I'm worried now that I picked that one, if you'd done that editorial for it. But it's a bit of a landmark paper, isn't it? Going to be
cited, it really is,
thousands of times. The other one, just quickly, Tumour Agnostic Therapies, Translating Scientific Breakthroughs into Global Implementation. First author, Jenny Liu from Sydney. It was an international group who wrote this position paper pointing out, again, with the advent of some tumour agnostic listings, how do we bring those benefits to the cancer patients more broadly, globally. So they discussed the current position and then talked about a 4-pillar framework for equitable implementation, including comprehensive biomarker testing capability, innovative clinical trial designs with decision support systems, harmonised regulatory approval and reimbursement mechanisms, and investment in genomically competent workforce development. See our recent discussion about the global workforce. So good on them for putting out this framework and again discussing what will be an important issue going forward. In a tumour-based paper, durvalumab plus chemotherapy for advanced biliary tract cancer. This is a post-hoc analysis of the Topaz 1 randomised clinical trial with some longer follow-up, up to 5 years, and median overall survival was 13 months for patients with durvalumab plus gemcis and 11 months for placebo plus gemcis. So hazard ratio there was statistically significant, but confidence intervals 0.64 to 0.88. So small benefit for these patients. I'm not sure if you have access to durvalumab in New Zealand or whether you would use it if you do.
It's obscenely expensive. So it is something I discuss with patients, but it's a small benefit. I think also, and correct me if I'm wrong, gentlemen, this trial presented PD-1 status, but didn't present MMR status within a biliary trial population. I'm pretty sure. And I remember having some concerns about that when it was first published, but I may be wrong. I'm furiously Googling.
I'm just looking through the tables. It's a short report. I don't think they've analysed it by DMMR, Kate. Clearly the curves separate, and there's a tail on the curve was, more long-term survivors. Reference our previous discussion in this episode, but it is a small.
Yeah, what increases long-term survival is by 10%, doesn't it? So, I mean, I'd frame it as it doesn't help 9 out of 10 people, and it actually helps 1 out of 10 people quite a lot. And that's an awful lot of money to spend for a 1 in 10 chance of improving your chance of being alive at 2 years. So it's definitely a statistical benefit. Is it clinically meaningful? It's certainly not a home run. And it's a minor incremental, really. And the financial toxicity is quite significant.
Great. And the last thing I want to mention was just a review, again, in the Lancet, prostate cancer. It's out in the current print issue. It's basically an up-to-date review of all the recent advances in prostate cancer. There's been a substantial number in the last 5 years. They talk about the new androgen deprivation therapies, advances in chemotherapy, new targeted therapies, and as well as lutetium, PSMA, radioligand therapy, and PARP inhibitors. So it is all there. And we mentioned in the last non-ASCO podcast as well, the new prostate cancer working group classification system as well. That's not mentioned in this paper, but otherwise it's, if anyone wants to, any trainees, pharma people, nurses who would like to read a bit more about prostate cancers, they've seen a patient, didn't understand what was happening, it's all there in that paper. That's it. Cool.
Sorry, just to hark back, 50% of patients, we didn't know what their MMR status was in the Topaz trial.
Well done, Kate. So they weren't being routinely tested at the time the study was set up, probably.
Yeah. And no analysis was made on the basis of MMR status.
Fantastic. All right. Great. It's lovely to see you all. We'll see you all again in a few weeks. Well, I'll see you all, and we'll all listen to us all in a few weeks.
And Rachel will try and not be too smug on Monday if her team wins the football.
Yay!
Good luck with that. All right.
Amatewa kakitiano.
Thank you.
Ta-ra.
That's it for this episode of the Oncology Journal Club podcast, where oncology papers meet real-world practice. If you'd like to explore the papers we discussed today, head to oncologynetwork.com.au and visit the Oncology Journal Club tab, where you'll find show notes, links to the research, and a growing collection of OJC resources. Don't forget to join the Oncology Network. It's free. You can send us voice notes and chat with us on social media. And physicians, you can also claim CME points for listening to this show. This podcast was proudly produced by the Oncology Network. Until next time, Thanks for listening.